Welcome. Today we have with us Dr. Laura Quinn. She's an MD and she's also a PhD candidate. And she's going to be speaking about the ELSA study. The ELSA study is recruiting 20,000 children in the UK to explore the feasibility and benefits of screening for type 1 diabetes. And she herself is a diabetes clinician and researcher interested in screening and immunoprevention for type 1 diabetes. She's completing a doctoral fellowship at the University of Birmingham to explore the feasibility and acceptability of UK screening versus via the ELSA study that we just noted. And excuse me, improved glycemic control from diagnosis and facility entry in order to basically improve glycemic control from diagnosis and facilitating entry into prevention trials. She states that we can only endeavor to prevent or cure if we know who's at risk. And we look forward to speaking with her regarding this effort. The ELSA study is very ambitious, but it looks like it's really underway and doing very well regarding recruitment and, data collection. Thank you so much, Lauren, for joining us.
Great. Thank you so much for the opportunity to speak this evening in the UK. I know it's first thing in the morning for yourselves.
No worries.
I'm a clinical research fellow, so I'm undertaking my PhD at the University of Birmingham, and I'm working on the ELSA study. So as part of my PhD, I'm interested in developing and testing a paediatric general population screening program for type 1 diabetes. So yes, I'm a diabetes clinician first and foremost, and that's where my interest in this field comes from. But I'm also a person with type 1 diabetes, and I have a lot of family with type 1. So it comes from a very personal place, this research interest. My supervisor, Professor Partharanjan, he can't be here today, but he's been an excellent supervisor and mentor to me all through the programme. And the ELSA study is co-funded by Diabetes UK and JDRF, who are two major diabetes charities in the UK. So in this talk, I'm going to give you a little bit of background to screening. Why on earth are we screening for type 1 diabetes? What's the rationale? What's the benefits? And then I'll talk you through the ELSA study, its objectives, and then I'll go through our recruitment data to date, how we're getting on, and some of our early findings from the ELSA study. There'll be time for questions at the end, and please put them in the chat as we go along as well. So screening, just to very much starting at the basics. So screening is where we take a healthy or apparently healthy population. We perform a screening test to see if an individual is at risk or has a condition. So therefore, because we're taking a healthy population, screening does do an element of harm. And therefore, if we're making decisions about screening, we have to balance the benefits and the harms. And this is a big question behind my PhD work, is what are the benefits and harms of screening? Now, if we think about type 1 diabetes, we can screen for genetic risk or we can screen for autoantibodies. Now, genetic risk, the great thing about this is it can be done on, say, a newborn blood spot. All kids have genetic screening for important conditions that are treatable. So we could screen for type 1 genetic risk at this time point. But there are some problems with genetic type 1 screening. It doesn't give you absolute certainty because of the environmental components of type 1 diabetes. And also, is it the right thing to do to screen all children at this time point? But autoantibodies is an alternative, and the antibodies usually arise after the 6th month of life. So that's when we think about screening in childhood, and that's what we're doing as part of the ELSA study. So the UK is quite different from the US in our approach to screening. We're quite reserved, and we're governed by the National Screening Committee, and the government has to receive a recommendation from this independent body before they'll implement a screening programme. So we've got to reach a very high level of evidence before any screening is implemented. And these are all the factors that they look at. So they look at the condition. Is it an important health condition? We all know type 1 diabetes is and carries significant morbidity, mortality. But it's the other areas we need a bit more evidence relating to. So the screening test, so antibody testing, as you may or may not know, it needs to be internationally endorsed. It has to be approved, your laboratory. It's not the easiest. The intervention, we don't yet in the UK have a treatment that can prevent or cure type 1 diabetes. So that's a stumbling block to screening. And then the screening program has to be acceptable. So it has to be acceptable to the general public, to the people it's going to affect who are at risk, and also to healthcare professionals. And this is a big part of my PhD work, is understanding the acceptability of screening. And then finally, it's about the implementation of the screening programme. Is there adequate staffing and facilities, for example, in our NHS? And also, is it cost effective? And with any screening, you're compromising something else if we spend millions of pounds on a type 1 diabetes screening programme. So we've got to make sure that the cost benefit ratio is there. So a very, very quick background to kind of screening to set us up. And we know from work by Ziegler, for example, that 3 in 1,000 children in the general population have multiple specific antibodies for type 1 diabetes. And it could be any 3 in 1,000 children. And the only way we'd know this is by screening for these autoantibodies. These antibodies are specific for the islet cells, so we call them islet-specific antibodies, and there's 4 antibodies that we routinely test for. We normally test for these at diagnosis when a child is symptomatic, but we're talking about screening healthy children who are asymptomatic. And we screen for antibodies because they tell us if that child is going to get type 1. So if a child has 2 of the 4 autoantibodies, there is an almost lifetime certainty of developing type 1 diabetes. So they're on that disease trajectory. And this graph shows that within 15 years, we're looking at 85% of those children will be on insulin. So it's quite a variable time frame. It could be 5 years, it could be 10, 15 or more. And that's the element of uncertainty that's difficult for families. They know this child is on the trajectory to type 1, but we just can't tell them exactly when that's going to happen. We're getting better at that with our risk prognostication markers, but we're still not quite there, that there is work to do. And then once we know a child has the antibodies, then we talk about staging. So in children who are at risk of type 1, HbA1c is not useful. That's a very late marker of hyperglycemia. So we look at more sensitive markers like glucose challenge testing. We can look at continuous glucose monitoring as well. And we do use HbA1c, and we look at the trajectory rises, but OGTT, glucose challenge testing, is the gold standard. And we use that to stage a child. So a child at stage 1 would be normoglycemic on glucose challenge. At stage 2, we've moved on to dysglycemia, but not yet hyperglycemic and not requiring insulin. And then stage 3 is traditionally where we diagnose type 1 diabetes. So this is a child with symptoms requiring insulin and the long-term type 1 diabetes. Okay, so that's the background. So what is the rationale for pediatric type 1 diabetes screening? So one of the elements is that with family history is of course important in type 1 diabetes, but 85% of the children that we diagnose with type 1 have no family history of the condition. So you're much more likely to come from the general population than you are a family member. So that's one of the rationales for general population screening. Of course, if you do have a family history, it's about a 4 to 9% chance of type 1. So it's still quite low. But again, that higher risk, these people are important to screen. So you need to screen family members and general population. And I did touch on genetic risk earlier, but it's not as predictive as antibody testing. So we've spoken about this, the antibodies. So we know that if a child is multiple antibody positive, within 15 years, 85% of those children will be on insulin. If they're single antibody positive, it's less certain, and the single antibodies can wax and wane, and that's why it's worthwhile monitoring these children, repeat antibody testing. But there's still a 14 to 15% chance of that child needing insulin in the next 10 years. So I guess one of the major rationale for paediatric T1D screening is DKA prevention. So in the UK, we still have 25% of children presenting in DKA. That's much higher if those children come from deprived families or regions, ethnic minority populations, and younger children as well. Children under 5, far more likely to present in DKA. So if we can prevent DKA at diagnosis, we know that that's a huge psychological benefit to the family, that they're not going through that traumatic diagnosis with type 1 diabetes. And I think that's where the strongest evidence is. We don't have strong evidence that DKA prevention improves long-term glycemic control. There's some early evidence for this, but there's nothing robust, I don't think, yet. We need more data on this to demonstrate that. But DKA prevention alone is one aspect of screening and a benefit. But I think perhaps the more recent phenomenon is immunoprevention. And on the 17th of November 2022, teplizumab was the world's first type 1 diabetes disease-modifying agent. And this was approved by the FDA. And it's now being utilized in the US. We had a call a month or so ago with clinicians who are providing this treatment. This is for individuals at stage 2. So they have 2 antibodies or more, and they're dysglycemic on glucose challenge testing. And this is a window of opportunity where we can modulate the immune system to delay the start of stage 3. So what we mean by that is we delay need for insulin by 2 to 3 years. Now, a lot of clinicians say 2 to 3 years doesn't sound like an awful lot, but I think this is a start in a much bigger picture. I think what we're learning about type 1 immunoprevention is that we need combination therapy. It's a complex immune disease. I'm not an immunologist, but one hit does not seem to be enough. We need combination therapies. We need adaptive immunoprevention trials to identify the best recipe, if you like, of immunomodulatory treatments to delay that even further. Could we delay it even beyond that, the 3 years needing insulin? So that's what the clinicians say. But actually, if you speak to families, the prospect of 3 years without needing insulin, without glucose monitoring, without dragging the child back and forth to the pediatrician is beneficial for families, and it means a lot to them having 3 additional years. So I think teplizumab is a start in the right direction, and teplizumab is being submitted to NICE, which is our kind of guideline organisation in the UK, to see if it can be approved for the same population for individuals aged 8 years and above at risk of type 1 diabetes, so stage 2. So we're waiting anxiously. And the thing is, with the ELSA study, we're screening people to identify those who could benefit from this treatment if and when it becomes available. So in terms of the screening landscape, so there's now screening studies all around the world. Frida has led the way in Germany, and has screened over 200,000 children and young people for type 1 diabetes autoantibodies. We've got the ASK study in Colorado. Sorry, this is just antibody screening. There's other programs that are doing genetic screening. But ASK has screened over 30,000 children. And ELSA in the UK, we've consented 18,500 children, and we've had the screening tests return for about half of those. So you can see that this is a real international effort to understand more about screening children for type 1 diabetes.
Lauren, I have a quick question for you. What kind of numbers are these different screening efforts trying to capture, just sort of generally? I mean, we know ELSA is going for 20,000.
Yeah, great question. So if you're screening family members with type 1, you would expect 2 to 5% to screen positive. So 2 to 5% of those children to have multiple autoantibodies. if you're screening the general population in Frida or the US, you'd expect 3 in 1,000, so 0.3% of those children to be multiple antibody positive. And that's exactly what we're seeing in the UK as well. So this is well-defined numbers in, say, Caucasian sort of individuals, but I think we're missing data in minority ethnic groups. So particularly Afro-Caribbean and Asian populations seem to be less likely to be autoantibody positive, but we don't have alternative biomarkers for those populations.
Yeah, and we just had a talk recently with Dr. Kate, and he was talking about searching for children with, progressing to type 1 in Africa, and that those children don't necessarily display the autoantibody profile prior to diagnosis. So it is kind of interesting to see the differences. But when we talk about the ELSA studies going after 20,000, a cohort of 20,000, what, is that is that the biggest, or are the others, in the same ballpark?
Oh, well, our 20,000, we powered it on our qualitative interviews. So
Yes.
of that 20,000, we wanted 60 kids who were at high risk, so multiple
Mhm.
antibody positive for type 1. And we've already reached that in the ELSA study, but that's how we powered our study. I mean, Frida's ongoing because of its success, and
Mhm.
Ask similarly. And we hope ELSA will continue. We hope to extend our age range from 3 to 13, and we hope to extend it to 2 to 24 years to start
Right.
to understand about young adult screening. So I think there's real momentum around this, and we're just trying to grow our cohort of high-risk kids.
And of the ones that are currently active, it's Ask, Elsa, and Frida, or the other ones also concurrently, or,
Oh no, I haven't even mentioned these. No, Adia in Israel ongoing, T1 Screen, Australia's ongoing, Can
Mhm.
Screen may just be opening up very soon. Triad in Sweden's ongoing, and Identify is a big European collaboration where we're taking learnings from these other screening programs and trying to roll it out to other healthcare systems and settings. So all of these are ongoing.
Okay, got it. And then once these data are generated, how accessible will they be for to the scientific population?
Yeah, great question. So there is a European registry, and there's now also a UK registry for all children identified as high risk of type 1 diabetes to go on to. And then the idea is for the European registry, the data remains with the principal investigator, so with the study team. But if there's a trial that a child might be eligible for, these trials can approach the screening teams and say, look, can we advertise this to your population? So it's all about collaboration. And that's really important, because if we're talking about children at risk of type 1 diabetes, they're rare, they're hard to find, and we
Mm,
need to work together to get the sufficient numbers to power an intervention trial. So
absolutely.
I know that about European and UK registries. I'm not so sure on the US front, but I can find out that for you.
I wanted to just sort of also bring to there's a big sort of open area there with China. We see a lot of papers coming from China regarding type 1 diabetes. And yet it's almost like a one-way street. I don't know, do they have a screening landscape in China? Are they communicating with these other partners, or is it kind of like they're a singular entity and it's just not, there's no cross-pollination?
It's a great question. I'm not aware of any activity in China, but that doesn't mean it's not happening.
Mhm.
My professor Partnerin recently went to Qatar and found out that they already have a screening program over there. So I think there are these little pockets of activity. It's
Yeah,
just I'm not aware of it. And actually, places like China actually has one of the highest rising incidences of type 1 diabetes.
right,
There's
right.
some sort of catch up with our kind of more European Nordic countries which are traditionally have the highest incidence, like Finland, UK, Sweden. We're seeing those higher rates affecting China as well.
Yeah, very interesting. Maybe a job for JDRF International.
Yeah, definitely. Yeah. No, we're very keen to work collaboratively though on this front. Yeah.
Right. More data is helpful. Okay,
Yeah.
so thanks for answering all those questions.
Yeah, no problem. Please interrupt me as we go along. So the ELSA study, so ELSA stands for Early Surveillance for Autoimmune Diabetes. We're screening children aged 3 to 13 years without type 1 diabetes. And we're aiming to assess feasibility and acceptability of screening. So feasibility, so how would screening roll out in a UK NHS model of healthcare? And acceptability, so what is the impact to the family? How do the family find or experience the screening program? What are the psychological implications, the cognitive implications, or health behavioral changes that you might see as a result of screening? This is what we're assessing via qualitative interviews in the ELSA study. And this is all led by our chief investigator, Parth Narendran, but as you can see, a much bigger team at the University of Birmingham and collaboratively behind this study.
Quick question, Lauren, from the audience. Is there any sample collection from these kids, or is it just a screening trial?
Oh yeah, no, it's like a screening program that we're testing. Yeah, so the screening test is via a dried blood spot. So this is just like a newborn blood spot card, like the Guthrie. We do a finger prick. We actually have 5 blood spots that we collect. This can be done at home. So the parents send a kit back to us in the post, or we can do it in community settings with a healthcare provider. And we've validated the 3-screen ELISA. So this screens for 3 autoantibodies of the 4. So it tells us if the child is positive or negative. And if the child screens positive, which happens in 1 to 2% of cases, then we recall the child for a venous collection. And then we do the 4 individual antibody assays for the 4 specific islet cell antibodies. So it is a 2-stage process, but there's a lot of benefits to that. So in children, you want to minimize the blood volume you're collecting. You want to make it as calming, pain-free as possible. So doing it in a home setting, parents have said, really eases the confidence of the child. It's more practical for the parent, not having to drag them to a hospital. So we've really pioneered this home testing with dried blood spot, and we've validated it, and we are submitting this manuscript imminently for peer-reviewed publication. And all this table is showing is that we met the manufacturer's guidelines for serum, which is a venous collection. And we've had a really good success with this screening test. We've had something like 39 blood spots returned insufficient sample out of over 10,000 via home testing. So it's a very effective screening test. We're not having to put children through a repeated screen, which is great.
So just to reiterate, what percentage of the blood spots have inadequate samples?
So yeah, or the percentage, it's something like 0.03%, so it's something like that at the moment. Yeah,
Great.
so very rare. Yeah. And then, as I said, we offer home testing to any family in the UK. So that's England, Scotland, Wales, and Northern Ireland can do the home testing, sign up free of charge on our website, and we send them a home testing kit. But we're also doing community strategies. And this is really important about raising awareness of type 1 diabetes, making the screening accessible, particularly for parents who aren't comfortable finger prick testing their child and might not have any experience of diabetes or finger pricking or what that involves. So we do actually run clinics in schools. We're working with our family doctors, general practices, and piggybacking on immunisations. So we're trying to identify strategies to make this as easy as possible for the families. And then we're also running community clinics, so going into the heart of the community, so particularly deprived areas or areas with sort of higher levels of ethnic minorities or other underserved groups like refugee populations, for example, and bringing screening to them. So we're testing all of these strategies to see what's the most effective, what's the uptake like, and are these feasible for a future screening programme. And then in terms of the study, so we do the dry blood spot screening. If that's negative, which it will be in 98 to 99% of kids, that's the end of the study. We tell the family, your child, we haven't identified any of the antibodies at this stage, but we do tell the family that antibodies can still emerge in the future. We can't avoid that. It's a cross-sectional screening test. But the older the child is, if they get to sort of 8 to 10 years of age and they're antibody negative, that gives you that bit more reassurance. Okay, this child isn't going to get childhood type 1 diabetes, but we cannot comment on adult type 1 diabetes. But yeah, so we do a one-off screen. If, as we said, if it's positive, as in 1 to 2% of cases, we do the venous collection to confirm antibodies. And then any child who's multiple antibody positive, we then bring them forward for the oral glucose tolerance staging. And then we do a one-to-one session with the family, telling them about what their screening results mean. We tell them about the symptoms of type 1 to be aware of, if not already. And we signpost the family to immunoprevention trials or tell them what's coming through the pipeline. And then we invite the family for an interview to understand their experience of the screening program from start to finish and anything that could be improved. And we direct them to this is our UK T1D Research Consortia, which is the home for all the screening studies, the immunoprevention trials, and everything is via collaboration offered on this website. So that's what the study looks like. And then getting into our recruitment. So this was a heat map, but this is actually a little bit old now. We will do an updated one when we get to our 20,000. But we hadn't opened Northern Ireland at this point. But you can see we're getting good coverage across wide parts of the UK. And then this map here shows you the follow-up testing sites. So if a child screens positive and needs a venous blood draw, this is where we'd refer the child to. So because it's such good geographical spread, it's minimizing the travel burden for families. And families told us that was really important. So these are our numbers. So 18,500 children now, as of the end of May, that have been consented to the ELSA study. The target for the end of this month was 19,000. So you can see actually we're not that far off target for such a high recruiting study. And then of this total, we break it down into children consented for home testing and children consented for community testing. So you can see about 13,000 signed up for home and just over 5,000 signed up for community. So now 1 in 4 of our consents are from a community setting, just showing how important that testing in schools, general practices is and the benefit is we're seeing more of the general population. When we first started the study, we got a lot of family members. We got 1,000 recruits in 24 hours, but most of them were family members with type 1. They're engaged, they know about the importance of screening. So it was an easy, low-hanging fruit, if you like, but very important. But now we're getting the message out to our general population, to our families that don't have any experience of type 1. And they're the groups we also need to target.
One more question from the audience. What percentage of positive blood spots are false on serum confirmation?
Yeah, good question. So on the dry blood spot, it's about 7% would be a false positive. On the serum collection, because these are validated diagnostic assays, the false positive rate is very minimal. I haven't presented the figures here, but it's in the realm of sort of 1 to 2%, because these are internationally standardized assays. So yeah, that's why the venous confirmation is important after the initial dry blood spot screening test.
Great. How many, what's the volume of the venous sample you take?
Yeah, so we we take as much as we can because we do use it for other biomarkers and other testing. It depends on the age of the child, so we will either take 4, 6, or 10 mil. In reality, I'm trying to think. I think it's only about 1 to 2 mil in total that we need for the individual ELISA assays. For the dried blood spot, we only need 50 microliters of blood. So that's why the DBS is such a good starting point.
Got it. Thank you.
No problem. And then this purple line, yeah, so we had 9,700. We've actually got 10,000 cards returned to us now. So you can see it's an ongoing trial. So there is a degree of non-returned kits from the home testing, but we do send messages out to the families to try and get these kits back and understand reasons for non-return. And if you don't want to do home, would you prefer a community setting? So it's trying to work with the family to support them to get the kit back. And then what this table shows is this is where we started. So our first 1,500 recruits, mainly family members, mainly sort of white background, very minimal minority representation. But if we then take our samples from April 24, we had 16,000 kids consented, and we had much better representation of the census data for England and Wales. So 82% white background, around 7% were any other mixed, 6.5% Asian or Asian British, and almost 2% Black or Black Afro-Caribbean. So you can see we've improved in our ethnic minority representation. We're still not quite at census data, which is our target, but we're heading in the right direction. And this has been achieved through community recruitment. If we hadn't have gone into schools, general practices, or community clinics, we would not have achieved that level of diversity. And we can see here, for example, in the community, it's a pretty even split. So a third non-white, 2/3 white. And then similarly for index of deprivation, this is an index where IMD 1 to 5 is the most deprived and IMD 6 to 10 is the least deprived by postcode. So we can see again, it's 50-50 split. We get good representation by going into the community from the more deprived families. And that's really important because ethnic minorities and the most deprived are more likely to present in DKA. And this is our model. These are examples of our community clinics. They're good fun. The families it's really acceptable to the families. There's really good uptake when we go and talk to them about screening. So it just shows that it's actually barriers and inequalities that are restricting access rather than the communities per se not wanting to do the screening. Obviously, that's our experience in the clinics we've done so far. But there probably are communities that don't want to do screening, and that's fine. But it's about having that informed conversation with these groups.
Question from the audience. Is there any difference in the rate of autoantibody positive children with race/sex?
With race, so sex, there isn't strong data for sex. The Frida study, for example, Teddy study have looked at male, female. We haven't really seen that. We're not particularly looking for that in the ELSA study ourselves. In terms of race, we do understand that ethnic minorities are less likely to be antibody positive. They're more likely to be single antibody positive, for example, at diagnosis. So it is perhaps that we don't have good biomarkers in these other ethnic groups. The biomarkers have been optimized in Caucasian, European, white US populations. So there is a piece of work to do there. And even in the ELSA study, we may not have the numbers of ethnic minorities to truly generate these reliable and validated biomarkers. But we will try. And I think another part of it is working together. These international screening studies working together to understand what are suitable biomarkers for these other groups.
Yeah, that's great. And then I guess at diagnosis, though, across the UK, what is the distribution of race? Is it equal at this point as everyone, as people kind of assimilate into I know there's been some studies where, people immigrate into the Nordic countries and then suddenly that population gets an increase in their type 1 diabetes diagnosis. So with the diagnosis, is it an equal spread across sort of minority and Caucasian, or is it still kind of different?
Yeah, it's still Caucasian predominant. So over 90% would be Caucasian background who are diagnosed with type 1 diabetes. Interestingly, though, if you look at deprivation, so most deprived to least deprived, that is equivalent. So over the five sort of quintiles of deprivation, the incidence of type 1 diabetes is equivalent, which is really interesting because even though it's equivalent, we know that those in the most deprived groups are more likely to suffer more diabetes-related complications, more health inequalities, more barriers to healthcare. So they are an important group to target as part of screening and diabetes care more generally.
Great. Here's another question. What is the age distribution of the screen participants so far?
Oh, yeah, great question. So, yeah, our median age is 8 years, and that's been the same all the way through. So have a good spread. We haven't, for example, seen. We wondered if parents would be less likely to screen young children because they're worried about putting them through a finger prick, they're worried about the distress, but we haven't noticed that. And also older children perhaps is our smallest group, if you like. And I think that's because with older children, you need to have that conversation with that young person about what the finger prick involves, what the findings might indicate. So I think that has led to some barriers to older children coming into the study. And it's why actually screening younger children is easier for parents, so they don't have to have that conversation.
Okay, got it.
Thank you. So once we've identified these children are at high risk of type 1 diabetes, what do we do? So we talked about the education session with the family to answer their questions. We actually incorporate resilience building into this. So trying to set a positive narrative for a future with type 1 diabetes. You know, many of these families, they may have been diagnosed 20, 30, 40 years ago, and their understanding of type 1 back then is very different to what we can do for a child now. In the UK, we now give all our children access to hybrid closed loops and continuous glucose monitors, and that's our standard of care. So it's a very different disease, the way we manage it, than it was 30 years ago. We do notify the child's GP and we ask for the medical record to be updated. We signpost to immunoprevention trials. There aren't currently any in the UK. We hope that will change by the end of this year. We let them know about teplizumab, that it's in the pipeline, and if and when it does become available, we'll let the families know. And then we signpost the family for monitoring follow-up. So we don't do this in the ELSA study, but the Enodia study, very well-established program for family members at risk. They'll also take our ELSA participants at risk. And then they track those children's progression towards needing insulin. And then finally, we can refer to a clinical psychologist. So we have distress questionnaires, and also in our interactions with the family, with the healthcare professional, if there's any concerns about wayward distress for the child or for the parent, we will do that referral. And that's a virtual appointment, usually 1 to 2 sessions are needed. So we're trying to build this package to support families with a child identified at risk of type 1 diabetes. We do now have a SNOMED code, and I know there's an ICD-10 code as well that was released just before this, but we now have these codes for pre-symptomatic type 1 diabetes. So these can be integrated into the health record. So whenever that child contacts medical services, it raises a suspicion of the clinician, could this be type 1 diabetes, you know, that I'm missing, to try and expedite diagnosis. Now, that's the benefit. There are also implications of this, implications for insurance, implications for example, travel insurance, future mortgages, life insurance. So there's pros and cons, and we don't really know where this stands with life insurance at the moment, or health insurance. We are trying to get this consensus from our organisations currently. But yeah, pros and cons to having a code for pre-symptomatic type 1. I'm very conscious of time, so just very, very quickly, our acceptability work with parents and stakeholders. So what I'm presenting here, this was work with parents and stakeholders. They hadn't been part of a screening program, they hadn't participated. We were just gathering their attitudes and views towards screening in general. And the parents told us it's beneficial to prevent DKA and have that time to prepare for their child with a future with type 1 diabetes. But there are implications. There's cognitive implications, understanding the risk and the differences between type 1 and type 2. There's uncertainty of living with risk because we don't know exactly when that child's going to need insulin, and possible behavioural implications. So the family trying to make lifestyle changes, change the diet, make the child exercise more, thinking that's going to prevent type 1 diabetes. In terms of diet, we don't have strong evidence or any evidence really. In terms of exercise, there's some animal model evidence, perhaps that exercise may increase insulin sensitivity, preserve some of the beta cell function. And based on this work, we're actually rolling out a trial called Extended, where children at risk of type 1 go into an exercise intervention study, and we see if it prolongs their time to stage 3 type 1 diabetes. So we're developing an evidence base in this area, in what is very limited evidence base at the moment. And I think that what the parents told us is education is really important. They need that positive narrative. They need that peer support because it's a difficult thing to go through a screening program. And they wanted access to psychology if they needed it. You never quite know who's going to struggle with a screen positive result. So it being available means that those that need it can benefit. Just coming to the end, and I'm very happy to take some more questions as well. But our lessons learned so far is that social media for home testing is an effective route for recruitment. But we've also realised that community-based recruitment is really important to access underserved communities, so those in deprived regions or ethnic minorities. Our next steps is thinking about implementation science, so working with recruiting sites, follow-up sites to understand what about the ELSA study has made it work so well, and what could we improve most importantly. Working with stakeholders to understand their acceptability for screening. I've already done all of the interviews with parents who've been through the ELSA study, and we're in the depths of analysis and hope to publish maybe later this year, maybe early next. And we're hoping to get to 20,000 children recruited by August 2024. So next steps for ELSA, as I said, we're part of this big European Identify bid to roll out screening more widely. We're now screening adults to identify risk of type 1 diabetes in adults via the TEDRA study, and that's also JDRF and DUK funded. And yeah, a big thank you to my team pictured here. This was our 10,000 cake, and we look forward to our 20,000 cake, which is going to be an antibody. So hopefully that will come in a couple of months. So huge thank you to the team, but also most importantly, thank you to the parents, the children and young people who've taken part in the ELSA study. It's amazing to think 18,500 children have been signed up to help us understand more about early stage type 1 diabetes. So a big thank you to all the families who've been part of this important work. So thank you very much for listening. I'm very happy to take any questions.
Thanks so much for taking all our questions in context of the talk. And I guess I would also say this is just a great effort for identifying those that could benefit potentially from teplizumab and other drugs of that nature. So there's some positive outcomes or some positive possibilities, let's say, for those that are identified as well. Is there anyone else who'd like to ask a question? If not,
I have a couple, Monica.
Yes.
Corinne, thank you so much for that presentation. That was really interesting. A couple questions I have. First is about how much does it cost to, the entire cost. So it looks like maybe 1 of 4 kits that you sent out haven't been sent back. So if you take all of that into account to get 20,000 blood spots and screen 20,000 people, about how much does it cost?
Yeah, great question. So we are doing cost effectiveness analyses as part of the ELSA study, and we haven't started those yet. We'll start when we get to 20,000 kits returned. In terms of the cost, so the dried blood spot kit, sending it out to family, getting it back and analysing it, that costs us about £22. So £22 per person. And then if you're thinking about things like the venous blood test, the OGTT, I don't know exactly. It's like a few hundred because of the interaction with the hospital and healthcare providers. The way we funded the study, we have a model in the UK called excess treatment costs. So if there's a program of research that may translate into clinical care in the near future, we can use the same costs as we use in the NHS. And we bring that funding over from the NHS into the research setting. So because we're kind of doing some of the work the NHS will have to do in the future. So all of our costs were at NHS equivalent, so at the best tariff price, if you like.
So another question I had that's somewhat related, you talked about your community model and how you did, you use social media to find some of these people, but I'm wondering your care model in the UK, you're an endocrinologist, correct? Adult, but most kids that have type 1 or young adults, do they see a pediatric endocrinologist, and are they seen in clinic? And also, like general screening, you didn't do any of this like in pediatric clinics where people have their pediatric, well visits and vaccinations and things. Was that used at all?
Yeah, great question. So unfortunately, in the UK, we no longer have a health visit for a child. The only visit is at 2 years of age. We scrapped that, unfortunately, a few years ago because of funding issues. So
How did they get vaccinations then?
But yeah, so the vaccinations are usually done in schools, most frequently. And then catch-up clinics are done at the family doctor. But that's why we've piggybacked on the public health programs, the vaccinations, for example, the school clinics. In Frida, every child at 10 years of age does have a community paediatrician appointment. Every child in the country. So they went along for that. They did the screening test. It was very easy for the provider to offer and deliver. And that's how they've screened 200,000 children. Unfortunately, we don't have that one hit in the UK, and that's why we've had to look at so many different avenues to see what's the best one. It may be in the future we have to say, look, we're going to screen every child at this age range, and it has to be delivered as a school clinic. That might be the most feasible model, but that's what we're trying to identify the feasibility of in the ELSA study.
So you mentioned that you were going for a number of about 60 when you were deciding on your study number, 60 positives.
Yeah.
And that you had already reached that before you were completely enrolled. And I know you had a huge group that had family risks, so they were at higher risk than those numbers were based on. Maybe that's why you got there early. But have you had an interim look to know how many are single autoantibody positive, how many are double?
Yeah. So interestingly, children in our study are more likely to be multiple antibody positive than they are single antibody positive. Now, we're using the ELISA assays. Other sister studies use perhaps more accurate techniques like LIPS or the ECL. I think that's the one used in Australia. And they're far more likely to pick up the single antibodies, the much higher proportion of singles to multiples. So again, it's something to do with the assay that you use, but it's why the confirmation testing is important, but it's also why follow-up testing is important. We need to repeat that antibody testing.
Thanks. Thank you.
Thank you so much, Lauren. We've taken a lot of your time here. It's really interesting. And, we look forward to the outcomes from this trial. And hopefully it will, bring new learnings to the field as a whole. So thank you again for all you're doing. Appreciate it very much. And we'll be in touch and speak with you again soon, I hope.
Thank you so much. Thank you for the opportunity.
Thanks again. Have a great rest of your evening. Bye-bye.